Welcome to the Dana Parrish podcast. Today I bring you a fascinating follow-up with former CDC Director, Dr. Robert Redfield. You may remember that last year when I interviewed him, he dropped a massive bomb on me and said that the original viral lines for COVID may have started in the United States at UNC at Ralph Barick's Coronavirus Research Lab. That interview garnered worldwide headlines, and I would say this interview is far more revealing than the last one. I was stunned by some of his revelations about COVID origins, the U.S. role in it, gain of function, the new NIAID director, long COVID. Today he's back with a new book called Redfield's Warning: What I Learned But Couldn't Tell You Might Save Your Life. It's a great book. I just finished it. I highly recommend it. Thank you so much for joining us. Please subscribe and share this interview and leave your comments and questions. I will do my best, as I always do, to get them answered and addressed for you. Great to see you again, Dr. Redfield. It's been almost an entire year, which I can't believe.
Yeah, thanks for having me again, Dana.
You have since written a book, and I think people are going to receive it so well. So the book is called Redfield's Warning: What I Learned But Couldn't Tell You Might Save Your Life. So my first question is, what are some of the things that you can share with us that may save our lives, and why couldn't you tell us?
When I really focus on the warning and what could save your life is I'm of the view, and I'm trying to get more people to be aware and of that view, that biosecurity is really probably the major national security threat that our nation has.
Absolutely.
Much more so than Russia and China and Iran.
Yes.
and North Korea. And we're not prepared for the biosecurity threat. We haven't prepared for it in a meaningful way. And so sort of the meat of the book is the last chapter, which is really trying to wake people up and say, we need to get prepared. We need to have a response in our nation that's proportional to the threat. And I sort of argue that for traditional security threats, we have the Defense Department, and we have bases all over the world, and we have contractors that make our missiles and weapons and bullets in the private sector. And it's an $800 billion, $900 billion a year industry to prepare to counter the traditional security threats. I argue we need to have something very similar for the biosecurity threats. So we need to engage the private sector so that we have antiviral drug development, we have vaccines, we have diagnostics, we have countermeasures, we have targeted medical devices. You probably remember during COVID, Mike Pence had to go up to Ford to ask Ford to shut down some car lines so that they could be converted to make ventilators, because our nation didn't have ventilators to support the number of people that needed it. So I argue we need to do this up front. And my own personal view is we should ground it in the Department of Energy. They have some good labs. They could manage the private sector contracts and really get the private sector to build the same type of robust support that we have for traditional, Boeings, Northrops, Raytheons, et cetera, we have for our traditional defense side. The other side of it, I think we should be smart about our policy when it comes to science, particularly gain-of-function research. I'm of the view that the COVID virus was a consequence of science. It wasn't a consequence of nature, that it evolved as a consequence of gain-of-function research. And that research, in my view, is unnecessary and has inherent dangers associated with it, which I do think is attested to the tens of millions of people now that have COVID, and the fact that we created a virus, so that is science created a virus now that will plague man for the rest of time.
How do we separate, gain of function from bioweapons research? Because aren't they kind of a lot of overlap there?
Well, they can be. I mean, you can have dual use research,
right,
where the purpose of the gain of function research is to make a bioweapon. But you can also have gain of function research where scientists are just trying to alter pathogens to study them, to try to learn what makes them pathogenic, what doesn't make them pathogenic.
Right.
I kind of disagree with Fauci and others that push gain of function research. They feel we need to do this to advance science. My view, and to be prepared for when a dangerous pathogen evolves from a non-dangerous pathogen. But the point is, I think that our scientific capacity can respond so quickly that we don't have to create the pathogen to know how to defend against the pathogen.
Right. But doesn't bioweapons research that continues pose the same or a greater risk?
Well, no, it's included. I don't think when I say gain of function
You
research,
mean all of it?
I mean all of it. I mean including the obviously use of that research from a bioweapon perspective. I don't think it should be done. The United States, historically, since I was in the military, canceled its offensive program and it only had a defensive program. But a defensive program can still potentially involve gain of function research, which I think potentially could end up with problems. I actually don't think the Chinese were intentionally trying to create a bioweapon. Some people disagree with me. I think they were trying intentionally to develop a biodefense weapon, that they were trying to develop a vector that could be used to vaccinate the Chinese military, the Chinese people, and maybe beyond. And that's why they wanted a vector that could be transmitted by aerosol or by air and droplets, because they really didn't want to have to use needles and vaccinate everybody. They wanted a vector that when you did get infected, you didn't get sick. So it was intentionally manipulated to be asymptomatic. And I think, again, that's why the interferon response elements were knocked out of this virus. I think that was all engineered. And then they wanted a vector that could be used over and over and over again. So they didn't want the human to develop the protective immune response that would then not allow that vector to be used again.
Yeah.
And I think that's why, if you look, and again, at some of the changes in the virus, it was engineered in a way that it doesn't develop an immunodominant response. And so we knew this pretty early on in the COVID pandemic, that I had patients that were getting their second episode of COVID within three or 4 months after the first episode. So that told me that even natural infection didn't prevent reinfection.
Right.
And all of that was engineered, in my view, intentionally. But I still argue, and I can't prove it, and I have some people that strongly disagree with me because they think there may have been more bioweapon intent. I think it was really part of the Chinese military's biodefense program.
There was a recent report by Robert Cadlick, I'm sure you saw it, claiming that SARS can potentially be linked to neurocognitive bioweapons research. And I wondered if you thought that was interesting.
I thought it was I have a lot of respect for Cadlick. I think it may be the report you're looking at is the continued work that the Chinese are doing modifying SARS. And I think he reported or cited a report that they've now taken SARS in the mouse model and modified it so that it had a propensity to infect the brain. And in doing so, they converted this virus now so that it's 100% fatal in mice. Now, that type of research, I think you would have a hard time arguing is a biodefense program. If you're trying to create a universally fatal pathogen that destroys the brain of a mammal like a mouse. Again, I haven't been able to independently validate that, but I think that's what Bob was referring to. There's no doubt that the COVID that we have also is a serious virus that interrupts cognitive function. And if you look at people with long COVID, probably one of the most important hallmarks of long COVID is cognitive dysfunction.
Yes.
So I don't know exactly the one you're talking about, but if it is the research that he commented about, the Chinese now taking the COVID virus and continuing to use gain of function research to modify its pathogenicity, so now it's pathogenic in brain. and in those mice, unfortunately, they were able to convert it to a highly fatal virus.
Got it. I have to look at the report, but I'm not sure if he meant that it was prior. It was not current. It was like prior research, and that the result is what we now call COVID-19. So you wrote in your book, this passage really stood out to me. It was sort of in the beginning. We were wrong to mandate vaccination. We were wrong to grant pharmaceutical companies immunity from prosecution. We were wrong to overlook the side effects of the vaccines. But without question, the biggest mistake we made was not admitting what we knew, and probably more importantly, what we didn't know. We changed every aspect of life in this country, too often without scientific or historical data to support these decisions. What was the real reason and the real agenda behind mandating the vaccines and this very coordinated spread of misinformation that went on throughout the world, but especially here in the US? I was, up close and personal with it. What do you think the point of that was? What was the real purpose?
Dana, I think first and foremost, it was, again, we helped develop these vaccines. The first ones were approved, I think, December 10th, 11th in 2020. And we were out of office in January 20th, 2021. Much of the vaccine policy developed in the United States then was developed after we were gone, when the Biden administration came in. I think first real problem was that no one allowed an honest debate about the value of these vaccines. And I think a lot of that was driven by personality. I think Tony Fauci's personality in particular, that people had made the decision that these vaccines were good and that everyone was going to need to get it. It was based on a false premise that and I think really misrepresented to the American public that somehow this vaccine prevented infection.
But they knew it didn't. That's the thing.
Well, that's the thing. All the data showed it didn't. They never admitted they didn't. If you remember, Biden and Fauci both said publicly to parents, vaccinate your children so they don't infect grandma.
I remember that very well,
Right.
but I also remember an op-ed in the New York Times in the summer of 2020, so months before the vaccines came out, saying we need a sterilizing vaccine. We need a vaccine that will block transmission, and that's not what this is. Eric Topol was on CNN, and I listened to the interview. This was prior, and he said, one thing you all should know, it's not going to stop transmission or acquisition of infection. So lots of people knew. Why were we? I mean, it just is so insane, and everybody lost their jobs and their businesses.
I think it was they were dishonest about about it for sure. That anyone who didn't agree I didn't agree with mandating the vaccine. I thought it belonged in vaccinating the vulnerable, those people over 65. I didn't think children should be vaccinated, and I sure didn't think it should be mandated.
Right.
Fauci had a different point of view. And basically the scientific community, the public health community, kind of followed that with no debate. And
what was the reason that he wanted to do that, though?
I don't know the answer. I don't know the answer. I think part of it is that he couldn't conceptualize that he might be wrong. All right.
But he had to know. Everyone else. I knew.
I argue he'd have to know. I would argue he would have had to know that it didn't prevent infection. I would argue that public health policy is probably not a strong suit. But he was wrong, for sure, in promoting vaccines, particularly mandating vaccines in the military, mandating vaccines for children, clearly making, I was on a call yesterday trying to help a person that, has pretty bad long COVID because of the mandated vaccine they had to take to go to college. So I don't. It'd be a good question for you to ask Tony.
He has a lot of power with grants and gain of function and biodefense. So I understand that. Why did nobody step in and say, and why is he the sole person to blame?
I think people tried. I think that the media empowered him. Tony was on the news from 6 in the morning to midnight at night,
Yeah.
all during the early parts of the pandemic. I had a criticism in one of my early briefings at the White House, where the president spoke, and the vice president spoke, and then Debbie Burke spoke, and then I
Yeah.
spoke, and then
Yeah.
Tony Fauci spoke. And when Tony got up after me, I was the CDC director. Tony was a lab person at NIH, right, and NAID. Tony got up and said, "First, I want to tell the American public that I'm the leading public health advisor for the country."
Oh, I don't, I didn't
Oh
see
yeah, he said
that.
it point blank.
But I
Point
do
blank.
believe it. I believe he would say that.
I point blank, and I afterwards I said, "Tony, I don't understand. What's that about?" I said, "I'm the CDC director. You run the lab. What was that about?"
And you're an
Uh,
IP doctor, and he's not an infectious disease
yeah,
doctor.
so I said, "What's that?" But he took it upon himself, and then it got to the point that if you said anything negative about vaccines, side effects, and forget about vaccine injury, but just side effects, they squelch that.
Right.
And if even they got CDC to no longer follow recurrent infections in vaccinated individuals. So Biden could say, this is an epidemic of the unvaccinated. And I said,
Right.
wait. Half my patients that are infected were vaccinated.
Yeah.
So it's not an infection of the unvaccinated. So now some people want to argue this was done for commercial reasons. I don't know that answer. And some people want to argue that this is what Bobby Kennedy talks about was pushed by corporate influence.
Seemed
That
like military influence to me. Doesn't seems way higher
The
than.
military didn't want this, from my perspective. Okay, but you got to remember, Tony was also not just the head of NIAID; he was the head of the entire biodefense program for the United States. That Dick Cheney in 2002, they took the defense programs. Biodefense program away from Fort Detrick and the U.S. Army, and they moved it to NIH and put it under Tony Fauci. So he had another
Right.
$40 billion to run that program.
Right.
And so, how much of it was he felt that he was infallible in vaccine policy? Clearly, he was aggressive and did not let the data define the policy.
There was also, though, Janet Woodcock, Peter Marks. I was given, 6 hours of Zoom recordings that were done early, like in 2020, late in 2020, early in 2021 with vaccine. People were in trials that were already getting severely injured, especially neurocognitive injuries. NIH was treating these patients in their own hospital, promising these patients, listen, Peter Marks and Janet Woodcock said to them, and I have records of it, like, we'll tell the public, don't say anything. We will come out with it. Don't worry, we will inform doctors. And they didn't. They still haven't. And they kept pushing it back. Give us a couple more weeks. Give us a few more weeks. So it was Fauci, it was FDA, like it was a lot.
Well, there's no doubt that that kind of stuff went on. I don't have a lot of, regard for Peter Marks. I mean,
No.
I think he was a huge problem,
Yeah.
and I think the FDA didn't do their job. I think I have more regard for Janet Woodcock, but the bottom line is they suppressed any information about vaccine side effects or vaccine injury or lack of vaccine efficacy.
Yeah.
And they sure didn't make sure the American public understood that these vaccines did not protect against infection. When I tell people, like I did the other day on a call with the mother and the girl who's quite ill from long COVID right now, who got the COVID vaccines in order for her to stay in college or go to college, the first thing her mother said, well, wait a minute, if it doesn't prevent infection, why did they make my daughter get the vaccine? I said, that's right. Well, that's right. You asked the right question. Why would you make her get it if it doesn't protect against infection? The policy didn't make sense. But, maybe someday Fauci will tell us why he got so far ahead of the data when it came to this vaccine. Some people feel that a lot of it came out of his lab, and he felt ownership to the vaccine, but it did a lot of damage, and there's no doubt about it that the degree of vaccine hesitancy we have today is huge as a consequence of the mistakes that were made in the vaccine policy for COVID. It's going to take a long time to try to regain that ground. If that ground is regained, I still believe that the COVID vaccine has a role in preventing serious illness and death.
For
Um,
who?
for
And
the
what, which, and
yeah.
which vaccines
Yeah, so
specifically?
it's for people, for me, it's for people over the age of 65. So I agree with CDC's revised recommendation. I do not recommend the mRNA vaccines for anybody.
Right.
I don't think we have enough knowledge about how long they produce spike protein and how much they do. So I only recommend the protein vaccine from Novavax.
And that's for 65 and over and immune compromise, is that?
I do 65 and over, and then for the group that's less than that, particularly say 50 to 65, it would be those people that have a severe risk for bad outcomes. So people that have body mass index over 35, if you're sitting there at 350 pounds, one of the real risk factors for bad outcome besides age was obesity. And then I worry about people with significant evidence of vascular disease, diabetes, type 2 diabetes, hypertension. I'm less worried about people that have cancer or have transplant, okay? Because remember, the vaccine doesn't prevent against infection.
This is not clear, again, to the public. There's a lot of talk about Novavax, and then there's also a lot of misinformation about Novavax. Does Novavax prevent infection?
Well, it's interesting. If you look at the data they presented
Mm-hmm.
to the FDA, it's
Right.
not approved for preventing infection.
Right.
But if you look at the data when they presented it to the FDA, because one of the, and it's all recorded, one of the people that were part of the committee asked the question to Novavax, and so Novavax answered it. And in their original study, if I remember, they had an 82% effectiveness in preventing infection.
Mm-hmm.
Now, the mRNA vaccines were in less than the 40%. I mean, they just didn't prevent infection at all. But Novavax doesn't advertise itself as preventing infection, and I still take the position that the COVID vaccines really don't prevent infection. But there is data, if you look critically at their pivotal studies.
Mm-hmm.
Now, Peter Marks was the problem. He got involved, and when Novavax was supposed to be approved, Peter Marks then weighed in, and I don't know why. Maybe it's relationships with Tony or whatever, but he weighed in and told Novavax that their vaccine wasn't pure enough for approval. They had a purity at that time of around 85%. It turns out they make their vaccine in baculovirus expression system, and there's a glycoprotein in the baculovirus system, which was very hard to purify the spike protein away from that. Okay, but 85% purity was pretty good for a biological recombinant product, and we have many recombinant vaccine products, including baculovirus express products that are approved, the flu vaccine, with purity rates of 85%.
Mm-hmm.
Well, Peter required Novavax, they could not get approval with their current purity. He said you need to get purity to the level of the mRNA vaccines. Well, the mRNA vaccines are a chemical reaction. It's very easy to get 95% purity from an mRNA vaccine. It's a chemical reaction. It's almost impossible to do that for a biological reaction, which is the recombinant protein. Novavax did go back, though, and eventually got their purity up over 90%, I think up over about 92%, eventually got approval. But that should have never happened. And also, what should have happened with the mRNA vaccines is they should have been forced to demonstrate how long does the mRNA stay in the body, how long is it actively transcribed to make spike protein, how long do people who get an mRNA vaccine do they make spike protein, how much spike protein do they make. The fact is, none of those questions were answered prior to approving it for the American public's use. So we don't know how long. And, Tony and others would say, well, it doesn't last very long. Well, that's not true now. We now know some people with the with the mRNA vaccine have active production of spike protein 6 months later.
And where is that data? Just because people have been looking to understand this topic better, is that data published at this point?
I think it's very hard to find, and hopefully Marty McCary is going to open up the door. This is where I'm a big fan to Kennedy. Kennedy's not anti-vaccine. What Kennedy wants is honesty and transparency about vaccines. The fact that the FDA, Pfizer, Moderna haven't put into the public eye all that they know about the vaccine injury, vaccine side effects, I think is unacceptable, and hopefully Marty will get that, and Kennedy will get that corrected.
I mean, I know a number of scientists who have presented different ways of studying it who were threatened, seriously threatened, and it's not just them. There's a huge amount of scientists who are interested and can't study vaccines because they will lose their career, lose their job.
Well, they don't want, there's a view, and when I was at CDC, there was this view that if you were to say anything negative about vaccine, the COVID vaccine, you were anti-vax, you were against vaccines, and that's not true. We just want honesty about it. What do we know about the safety? I now am in clinical practice, and long COVID is largely my practice.
Yeah.
But about 10% of my practice is also mRNA vaccine injury.
Sure.
And these patients have really struggled because the clinical, physicians and clinical system has told them that they don't have vaccine injury, that it's all, it's all in their head. No,
well, they're told that because the FDA didn't inform them, right? I mean, isn't that their job that the FDA should be?
I think that's why Marty's got to come out and make it clear, that vaccine injury from mRNA vaccines is real. And I think if you're following this closely, Dana, the Europeans are relooking at this very carefully right now.
Yes, I also though do think it's a problem with Novavax. I mean, I know the same injuries, the spike. I mean, I'm not really.
I haven't. I mean, my clinical practice, and I probably have the largest clinical practice of Novavax in the country. I have not seen that data in my experience. I have not had people develop significant long COVID-like illness from Novavax. I'm not saying it doesn't exist, and this is why I think the FDA should just show us all the data they have on vaccine injury on the COVID vaccines.
Right. So you talked a little bit about your clinic, which is so interesting. How virulent...
I have to be careful about doing your podcast. So last time I did your podcast, my clinic filled up for like 2-3 months.
Where's my 10%?
I don't get anything. I work for a hospital system.
Okay, well, that's unfortunate. Then we shouldn't talk too much about your clinic. But how virulent right now in 2025 is SARS-CoV-2, is COVID?
Yeah. It's an important question. And it's one where I look at this probably in a countercultural way. Okay, so when I'm in these meetings with other scientists, there's no doubt that the Wuhan strain is much different than the circulating strains today. Okay, and then the Wuhan strain and the UK strain and the Delta strain, those were the first 3 major strains that we had.
Yeah,
and that virus was interesting in that it liked to replicate in the lower lung.
Right.
And so that's where we saw a lot of respiratory insufficiency.
Those people, did they recover? Did they get fibrotic lungs?
Some people did. Some people didn't. It was a lower lung disease, and that's where people start thinking of COVID as a pulmonary disease. It's really not a pulmonary disease. It's a blood vessel disease. And when Omicron came, one of the things that people didn't highlight is that it totally changed where that virus likes to replicate in the human body. So now it replicates in the upper airway, the throat. And if you remember, one of the hallmark symptoms of the Omicron was sore throat.
And that's what's going on now?
A similar virus to the Omicron strain. That's right. So it's become progressively less symptomatic in the American public. Now, how much of that is the pathogen is so much less symptomatic? Or how much of that's because the American public all has pre-existing immunity because we've all been infected? I can't answer the question, but it's definitely causes less obvious symptomatic disease if you get COVID today than it did if you got COVID in 2021. Now, it's interesting. Most people see that as a good thing. I'm countercultural. I don't necessarily see that as a good thing. Because when you look at COVID, what's the real problem that we're facing with COVID today?
It's the long term.
It's long COVID. So when you look, is long COVID more or less likely in somebody that had more or less pathogenic infection. And there's something, I'm a virologist, there's studies that were done. Hepatitis B is an interesting virus, which in most people, 90% of people, when they get it, they'll clear the virus. 10% of people, approximately, will not clear the virus. They'll become chronic carriers.
Yeah.
There was a study done by a guy named, I think it was Malcolm, in Alaska in the 80s, and he was prospectively studying, looking for hepatitis B among Eskimos, which have high carriage rates. And so they were prospectively drawing blood and prospectively evaluating people who developed symptoms. And at the end of the study, I think it was a couple-year study, they had a group of people that had been diagnosed with hepatitis B clinically. And then they had a group of people that were diagnosed in retrospect with hepatitis B because of the blood test, right? They seroconverted to hepatitis B. Of the group that were symptomatically diagnosed, 3% became chronic carriers. Of the group that they didn't diagnose clinically, but they figured out because of the seroconversion, 14% were chronic carriers.
Wow.
It suggests to me, and this is what I believe as a virologist, that you're much less likely to develop chronic infection from a virus that can cause chronic infection if you get sick. So those of us that get symptomatic COVID are more likely, in my view, to clear COVID.
And is that because the immune response is better? So you get a
the immune
fever, it's
response-
killing it.
the immune response is really important in terms of the whole mechanism of clearance. And for those, and these are for viruses that can either be self-limited or chronic, okay? It's some viruses like HIV are just chronic. With COVID, we now know, and I'm pretty convinced that a majority of the reason you get long COVID is you never cleared the virus.
Right.
The virus is still in your body.
So just to
And
be
I'm
clear,
gonna
you
argue
think
that
it is
you-
persistence. It is viral
Yeah, there's no
persistence.
doubt about it. There's viral persistence, and over time, most patients resolve their long COVID. So that means I think they probably get rid of their viral persistence, but that may be measured in 3 years, 5 years, 7 years, whatever. But I suspect that this is a long-winded way of saying about when you're the question now that the virus is less pathogenic, is that a good thing? I think we're going to see more long COVID. Long COVID is not a good thing.
Agree. I'm concerned about the chronic nature of the virus. And I'm wondering, how are you differentiating at this point in your clinic between, do you have a certain test that can rule out chronic virus versus vaccine injury? How much of it is driven by spike? Is there overlap? Are they two different diseases? All those questions are on my mind.
Yeah. So my thinking's evolved because I like data. I used to think 3 years ago, 4 years ago, that the driver of long COVID was spike protein. It's an immunotoxic protein.
Right.
Today, I think the driver of long COVID is viral persistence.
Yeah.
Okay. And part of that viral persistence, of course, is spike protein, but it's viral persistence that's driving it. Okay. And that opens up ideas about how to get rid of long COVID.
Right.
Which is if we could get rid of viral persistence, either with prolonged antiviral therapy, which is one approach, or another approach I'm working with a group that I'm very excited about, where they've seen that the people that have long COVID lack cellular immunity to a variety of the key epitopes in COVID. And that's interesting because the cellular immunity is what's actually responsible for clearing viruses. So if you now lack that cellular immunity, that may be one of the reasons you have persistence. Okay. And then the question, can you figure out how to reinduce cellular immunity that would allow viral clearance? And I'm optimistic because, again, the natural history of long COVID, if you follow patients, say, over 5 years, is they do progressively get better. Now, the exception is patients that have mRNA vaccine injury. I don't see them getting better at the same pace. Now, when they have vaccine injury from mRNA, they're not making virus, but they probably are making spike protein. All right. And that so the immunotoxic effect of spike protein can also cause significant disease. How do I tell the difference clinically? Well, first, by history, I listen to the patient.
Sure.
And patients will say, 3 weeks after I got my booster mRNA vaccine, I got sick.
Yeah.
Okay, and bam, 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 bam. And when I can look at them, their blood for antibodies, and I can find that yes, they have antibody to spike protein, but they don't have any antibody to nuclear capsid, which
Right.
means they've never seen the virus.
Right.
Okay, now often it could be both. You could have had previous COVID infection and then still later gotten vaccine injury,
Are
and
they
so.
enhancing each other? No, I'm
No,
concerned about antibody-dependent enhancement, which I
yeah,
wanted
I
to ask
think
you
you
about.
you should be concerned. But sometimes I wonder if one of the reasons we're seeing so much COVID transmission is there is a degree of antibody-mediated enhancement.
Yeah.
I don't have any data to prove that in one direction or the other. But I do think it's possible that active immunization of the population in retrospect made we see these new variants, for example, like Omicron, you see these new variants. One of the things that hallmarks is that they're more infectious, less pathogenic, but more infectious. Or
Right.
are they really more infectious, or is there antibody mediated enhancement because of pre-existing immunity?
There is that data from Cleveland Clinic that has been on my mind for a long time. I did mean to ask you this when we spoke last year. There's that paper that says they were very surprised to find that the more vaccines, I think it was 3 or more, increased the amount of infections people were getting.
Part of that was raises in me the question of whether or not the vaccines were inducing antibody-mediated enhancement, right?
Right.
But I don't know the answer. But I do think there's enough data to be suspicious. And obviously I've already stated, I think universal vaccination with the COVID vaccines was a mistake. I still believe, and people challenge me, I still believe there's still data for people over 65 that being vaccinated adequately, and that's probably every 6 months, not with an mRNA vaccine, but I use the protein vaccine,
Right.
that those individuals are less likely to be hospitalized and die. But I have people that will challenge me, and even on your podcast, there'll probably be stuff in the comic. I don't believe that. There's no data for that. So
Why not recommend early treatment? That to me, you and I had a really
good.
great discussion about antivirals when we
Yeah.
spoke last, and I loved hearing from your virology point of view why they were the most important thing, and
Yeah.
there should have been an Operation Warp Speed. Personally, I would only take early treatment. I would not take a vaccine for
And I
COVID.
think that's fine. I have lots of patients now that's my recommendation for them, because a lot, even some of the people at high risk over 65, 70, they're not going to take a vaccine. So what I do for them, and I don't badger them, I say, I think, an alternative and definitely a great idea is just keep a home test. If you get sick, take a home test, or if you've been exposed. And if you do have COVID, let's get you on Paxlovid or Molnupiravir within 48 hours. I don't want them to take it right away, because
Right.
if you do treat within the first 12 to 24 hours, you have a much higher rate of relapse. I
But
mean,
why not give it for 10 days? Add some
I think
metformin.
you think you should give it longer. I'm the chief medical officer for a publicly traded company called Tros Pharma.
Mhm.
It's on NASDAQ. We're currently in phase 2 trials with an anti-COVID antiviral, which I think is far better than Paxlovid. It doesn't
Yeah.
require ritonavir. And we're treating people for 10 days. I expect that we're going to show less rebound. And then if it goes well, my really goal is then to go into treating for 30 or 60 or 90 days and see, do we decrease the incidence of long COVID? All right. And that's sort of the goal that we're going to do. And then, of course, that's the same drug that we would try in a group of patients with long COVID to see if we treated them for 30, 60, 90 days. Could we change their natural history? I do agree with you. I think 5-day with Paxlovid is inadequate antiviral therapy.
Yeah.
I think that if we don't treat you and you get COVID, you have a 3% chance of rebound. If I
Right.
if I treat you with Paxlovid, you have about a 20% chance of rebound
If you treat me for 5 days,
if I treat you for 5 days.
which we know stinks. It stinks.
So, but that's what's right. If I treat you for 5 days,
Yeah.
you end up actually with a 20%, where if I don't treat you at all, you end up with a 3% chance. So
What if
in
you
other
treat me
words,
for 10? What if you add metformin? What if you add supplements and even
yeah,
ivermectin? I know it's like, I'm not going to subscribe to the nonsense about that stuff.
I don't know the answer. I will say many people end up getting treated, as you know, for 10 days, because once they relapse, they get treated again with Paxlovid. I personally think that and this is what we're studying in my trial with the drug that we're developing,
Right.
we're treating people for 10 days.
Great. Look, I talk to a million doctors. I do not see long COVID from people who were adequately treated early on. I don't hear about those cases. Very rare. And I'm curious, in your clinic, do you have people that say, hey, Dr. Redfield, I did 10 days. I wouldn't let myself relapse. I do the 10 consecutive days of Paxlovid and all the other stuff. Are you seeing long COVID in those early treated patients?
I see long COVID. I don't have patients that are treated for 10 days or 20 days. I have patients that were treated for 5 days.
Sure.
Okay. And I will tell you that I have plenty of patients that went on Paxlovid or Molnupiravir, were treated for 5 days, and now have long COVID.
I understand that. I
But
totally
I
can
don't know
see
what would
why.
have happened if they were treated for 10 days. Okay. I believe that the current antivirals that are used in acute COVID are inadequate. Okay.
Yeah.
Partially because of their own potency, but also partially because of the duration of treatment.
Yeah, my dad was in the hospital for COVID, and he was really sick, and it was really terrifying. And they wanted to give him remdesivir, and I said no, you absolutely will not give my father remdesivir. And it just killed my friend's dad, and I'm not doing that. And I said I want him on 10 days of Paxlovid with metformin and doxy. My dad in 2 days was like home, or 3 days, feeling fabulous. Whatever long-term stuff that I was expecting him to have, or whatever horrible outcome, was completely mitigated. And it was like a turning point within a couple of days, all those things together. I love that treatment. I've not seen any failures with that treatment,
Yeah,
to be
it'd be
honest with you.
interesting. Again, it's just important for these things to be, as you pointed out, just adequately studied. I mean, it's not a complicated study to do Paxlovid versus Paxlovid plus metformin. It's not a complicated study.
Why
It's
hasn't it
just,
been done though? I mean, like,
I
here
don't
we are
know.
5.5 years
I,
in. You're an
Well,
HIV guy. I
the
mean,
first problem was, for the longest time, the established didn't believe long COVID existed. I mean, I won't tell you how many, in my first 5 years, I've been in practice for long COVID now for 5, 6 years. My first 2 years, all my patients came to me from psychiatry because they had gone to
right.
psychiatry because everyone said they were crazy. It was all, it was all reactionary. It was
What's
all
that about? Is it the denial of chronicity? Is it the denial of long term, with chronic
I think
Lyme and
it's
all these things?
the inability to have a test to tell you that that's what it is. I mean, we've gotten away. I mean, when I started my practice 5, 6 years ago on long COVID, I tell people that I really feel I went from being a pretty sophisticated clinical research internist, I became a psychiatrist. Because what I did for the first 2 years is I just sit and listen to patients,
Yeah.
and I became convinced that these people were really sick. And I could do a lot of tests, and none of my tests were abnormal, but they still were really sick. And I gradually learned how to recognize long COVID cognitive dysfunction, or how to do the autonomic dysfunction, and eventually some of the things I could get my hands around because I could get a test to prove it. The ones that have pelvic vein compression syndrome, but I think most doctors, when they do a study and everything's normal, they assume that it must just be in your head.
Well, they don't, yeah. And I mean, I think a lot of times they're not even doing the correct tests and
But
evaluation. And you kind of, you're listening. And that's one of the most important parts of this evaluation, is to take a great
sit and listen.
history.
I've seen very many people. They've taught me a lot. And the one thing they've taught me the most, and I've seen some people that are quite ill, but I will tell you, almost universally, not universally, but over 85% of the patients I've seen, even the ones that are quite ill, within 3 to 5 years have gotten better.
That is
And
with long COVID.
with long,
What treatments are you seeing benefit with that you're using in your clinic or in your practice for both long COVID and also separately for vaccine injuries, if you have treatments for both of those?
yeah. So right now, I haven't distinguished the treatments, although I do think that there may be a need to distinguish the treatments.
Mhm.
I will say my observation is there's been a difference in clinical response,
Mhm.
that the long COVID have more favorable response than the long COVID-like vaccine injury. Okay.
Mhm.
Um, so it turns out it depends what the issue is. So if the patient's dominant issue is, say, fatigue and cognitive dysfunction, inability to concentrate, loss of name recalling, inability to read. So it's a cognitive issue that's driving it. I've found a lot of success using Maraviroc, which is a CCR5 antagonist that was developed for HIV, which I've used a lot in my HIV practice,
Mm.
and another drug called rapamycin or sirolimus, which is a transplant drug.
Yeah.
And I've sometimes combined that with probenecid, which is an old gout drug. That cocktail has, I've probably cognitive dysfunction gotten 75 to 85% response rate. Okay.
Wow. And this is with long COVID.
With long COVID. I mean, I have people that cannot speak more than 2 words, 3 words at a time, that on treatment get back to speaking normally. And when their pharmacy plan doesn't renew their prescription within 3 to 4 weeks, they can't speak again. And once I argue and get them their medicine back, they speak again. I have a
Wow.
number of patients that are very smart and avid readers who've gotten to the point that they cannot read, and because they can't retain anything more than a couple paragraphs. They don't read books anymore.
Hmm.
And I've been able to get them on this regimen, and within a month they're reading. One guy comes in, he says, "I can't believe I'm reading again." I said, "Well, what are you reading?" He said, "I'm reading The Rise and Fall of the Third Reich." I said, "Well, that's a little heavy." But I got them back reading, and I've got wonderful letters from my patients thanking me for giving them back one of their joys of life, which is
Wow.
to read.
Wonderful.
I'm an advocate, and I've used that now in some patients that have been burdened with peripheral neuropathies that haven't made sense, burning pain on one side of their
Yeah.
body, joint and burning pain. And I have one in particular, State Department person, who I finally decided, hey, I don't have anything to offer this person. Let's go ahead and try. And they responded. So I probably have now done about a dozen people that's largely peripheral neuropathy, and I'm getting some response.
How are you
Okay.
dosing the
Well, 300,
rapamycin?
300 milligrams twice a day.
The rapamycin?
No, rapamycin, 1 milligram, 2 milligrams a day.
Oh, a day. You're not doing it once a week or twice a week. It's
No,
every day.
every day.
Interesting. That's so
Okay.
interesting.
One milligram, 2 milligrams a day.
Okay.
And I tell them I'm not doing it as a longevity doctor.
Hmm.
Okay, because a lot of these patients also go see natural doctors, right? I mean,
Sure.
and some of them come in with a suitcase full of natural medicine, some of which I find really improve their condition, and some of which I'm not sure they benefit. I never talk it down because I don't have the answers, and I encourage the patient, if they can get good advice from somebody that thinks differently than me, so be it. So those patients, now the patients that have some problems with cognitive dysfunction, and maybe where I think they may have microclotting and hypercoagulability because of fibrin clotting. And I work with Jordan Vaughn down in Birmingham, where he has a special test that he can assess the degree of fibrin clotting. And if he shows me that they're really off the charts in microfibrin clotting, I've treated them with 3 anticoagulants.
Oh, what are they?
Okay. Eliquis, Plastin, and aspirin.
Do you use nattokinase or serrapeptase or any of these kinds
I
of?
don't. I haven't. I have a couple people on it. Vaughn uses it.
Mm-hmm.
Okay. The other thing I didn't mention for the cognitive dysfunction and for the hypercoagulability, I go after mast cell stabilization. So I use pepsin. I usually use 40 milligrams twice a day. Some people 20 milligrams twice a day. And I use another drug called tenofovir, which is not available in the U.S. other than going to a compound pharmacy. And that's really designed to stabilize the mast cells.
Interesting.
More so in people that give a history where they're maybe getting more atopic, more allergy, or they get a cold, and rather than be sick for 2 days, they're sick for 2 weeks. But in general, I'll do mast cell stabilization. The one that I'm most excited about because I've cured people is the patient that presents with a history, and I have a number of them now. They present with a history that they can't breathe. They're hungry. They actually use the word, they're
Air.
hungry for air.
Yeah.
Okay.
Horrible
And
feeling.
it's a horrible feeling.
I had it. It's the worst thing I've ever had. Not related. I had it related to Lyme, and I literally thought I was going to die, and I was homebound because of that symptom for months. It
Well,
was
they all think they're going to
torture.
die, and I try to
Yeah.
convince them they're not, and that helps
Yeah.
keep them out of the ER after a
Yeah.
while.
Yeah.
But they've all, by the time they've come to me, they've already been cardiac workup, including many of them cath, and they're normal, right? They've
Interesting.
had a pulmonary workup and everything in pulmonary, and they're normal, but they can't breathe. And so they're all sent to psychiatry as being, having a psychosomatic response. Okay. No, these people really feel like they can't breathe. They're hungry for air.
Yeah.
So I said, well, after listening to them, and if you hear this story like 6, 7, 8, 9, 10 times, you kind of say, well, maybe this story's like real. Why can these people not breathe? And so I postulated that maybe they're not. I did other things in the history, like do they feel better when they're in a swimming pool? Any position make them feel better? But long story short, I postulated that maybe they're not returning the blood to their heart. That it's getting stuck in the veins. All right, and so 70% of our blood supply at any one time is in our veins. And where could someone end up getting more blood stuck in their veins? Well, the place that would be in the pelvis. And it turns out the anatomy in the pelvis is such that the iliac vein is such that it goes right underneath the iliac artery. And the iliac artery is able to compress the iliac vein. And actually, it's like you would put your finger on and stop it so it can't get its blood back to the vena cava. And long story short, I go ahead and do MRVs, MRAs of the pelvic veins, and lo and behold, I prove that these people are compressing their iliac veins.
Wow. And why is that happening?
Because the COVID virus, I told you, is a blood vessel disease, and it's weakening the integrity of the lining of the veins.
Yeah.
So the veins now become like an overstretched balloon, if you will. And so anyhow, I prove this, and I can show you tons of venograms showing this, that they're compressed. And every week I see a new patient who comes in. At least I feel good because as soon as they tell me they can't breathe, they're hungry for air. Some of them have a tendency to be hypermobile, double jointed. So they've had a collagen issue anyhow, and now it's just exacerbated. When you look at their venograms, also in the pelvis, what their pelvis veins do to compensate is they create new veins.
I see.
Right? And so now, rather than have these two iliac veins, now you have a network of maybe 10 veins. And now you have veins that, like your gonadal veins and stuff that are supposed to be small, now they're getting huge, but they're not going back to the vena cava.
I got it.
So you're just sucking all of this blood. So some of the patients, before I figured this out, I would send for IVs once a week, and try to have them increase their salt intake and Metadren and stuff, spend more time in the swimming pool. But now I figured this out, and I go ahead and get these studies and show they got compression. And I used to send them all to Denver, but now I have a person in Annapolis finally, so I don't have to send them to Denver. I have an intervention radiologist that goes ahead and puts a stent in the veins to keep the veins open.
Wow. And that just
And,
magically
and
just,
they're better overnight.
you're kidding.
Well,
Is,
I
that's
have
incredible.
I have a letter. Wait, let me grab. I have a letter from one of my patients who just sent me a letter. This guy had already written his will, told his children and his wife he was going to die. He said goodbye to him at the age of 47.
Wow.
I'm just going to get this letter. It's very hard to find enough words positive to thank someone who just saved your life. But he wrote me a beautiful letter about, and I think it's a beautiful letter, and he just wanted to thank me for figuring everything out. And he tells the story. He believes in God like I do, and he thinks it was sort of a gift from God. And I tell him it was. But he literally went and had this procedure. And when he woke up, he could breathe for the first time in like 2.5 years. And he went after 2 days later and he climbed Pikes Peak and he's feeling great.
That is
So
remarkable.
I now have a couple dozen of these patients, and but who would have believed that long COVID would cause pelvic vein disease?
What about that? Now, when I spoke to you the last time, you talked about a suffocating syndrome that the vaccines were causing. Is
Yeah.
it the same thing that
Same thing. It's the same thing. So you saw it when I talked to you last time. We were talking about another patient that I had. He was one of the early ones that I figured he's definitely a vaccine injury, and really one of the great geologists in our country, one of probably the top five. They built most of the airports in our nation.
Wow.
And he can't function anymore. All right. And of course, it's all happened after the mRNA vaccine. And we did prove, unfortunately, that he has pelvic vein congestion syndrome. And we did put stents in him, and he was all vaccine injury. Now, he hasn't got he didn't get as good a response. He got a response, and he's better, but he didn't get the same degree of response that this patient I just told you about.
Why do you think that is?
I don't know the answer. I don't know the answer. I do think the pathogenesis of obviously causing prolonged symptoms post-COVID and post-mRNA vaccine are probably different.
Interesting.
They're similar, but they're different.
So monoclonal antibodies, I was talking to David Petrino this morning. What about that as a treatment for both long COVID and vaccine injury? Could that be beneficial for these patients? And if so, what do we need to do to bring these out? I heard about this company that people seem to like called Invivid.
I mean, I do think I'm of the view that, again, going back to what I think is the underlying pathogenesis of long COVID, I'm of the view that it's viral persistence. And I'm of the view that it's the body's inability to clear the virus. And I'm of the view that the part of the immune system that's responsible for that final clearance is the cellular immune system. So I'm looking at ways to look at immunotherapeutics that might stimulate or induce that cellular arm of the response. But I'm not obviously negative to looking at the potential. I think it's going to be more of a cellular response. There's no doubt that antibodies are very effective therapeutically when you have acute COVID. And they may have a role in chronic COVID. I'm not sure that a lot of the long COVID symptoms are really driven by a lot of virus. It's just driven by persistent virus, if you know what I mean. Enough virus to make the immune system go in the wrong direction.
Right. But I do think it's important to explain for the person watching this that doesn't understand even what we mean. The virus can disseminate, I mean, better hearing from you, to all your organs, to all over your body. You know, you can get a mild case, as we talked about, probably even asymptomatic case, and it can end up where? In your heart, in your brain, in your spleen, in your tissue, right? And cause disease.
Yeah, it could either be the virus, or as you commented and I commented, it could be the virus or it could be the viral proteins. The problem with COVID, and this goes back to my own view that it was engineered.
Mm-hmm.
It was engineered to have a high affinity for the H2 receptor,
Right.
which is a key receptor in our body. It lines all of our blood vessels. It's everywhere. It's in every organ. And when the virus or the viral protein, the spike protein, binds to that receptor, it triggers a series of events. All right. So for me, for example, the veins and the veins in the human body, it obviously I think weakens those veins.
Mm-hmm.
All right.
Yeah.
Sometimes in the veins, it sets them up for microcoagulation.
Mm.
Now the virus itself, whether it binds or whether it's the viral proteins that bind, I don't know the answer. I think the virus persists though, and so it's constantly making new proteins.
Right.
And those new proteins are causing problems.
So you're an HIV pioneer, and I have to ask because everybody has been talking about some of the drugs that some of you are using to treat COVID that are helping. You talked about mRNA. There are other antivirals that have translated from HIV that seem to be helping some patients. And the words airborne HIV get tossed around quite a bit these days. And I wondered if you find that there is any genetic or functional truth to the claim that COVID is similar to HIV, or you could even say it's like airborne HIV.
Yeah, I don't see that analogy, me personally.
Okay. What do you make of?
Some people may get to it a little because when I said that the COVID virus has been engineered so you don't develop a dominant immune response that then is protective, so you can use it over and over again.
Mm-hmm.
Some of those changes in the virus are similar to what we've seen in HIV, but it's not to say that this virus is anything like HIV.
What about the immune suppressive aspect, the T cell dysfunction? Just saw in the UK a graph that showed a rise in Kaposi sarcomas in the last couple of, maybe the last year or two. And so again, it comes up.
I mean, there is obviously concern when we go back to the mRNA vaccines, whether there's other nucleic acid that may be in those vaccines that may be associated with neoplastic disease. I know the Europeans are big on that. A guy named Gustaglis in
Yeah.
London is big on that too.
Right.
But in terms of general immunosuppressive, it's clear that long COVID induces significant immune dysregulation.
Right.
And therefore, who knows what the consequences of that immune dysregulation is. It's pretty severe. We've got pretty good data that people with long COVID really do demonstrate what we call T cell exhaustion,
Right.
meaning their T cells are exhausted, which is probably not a good thing.
Right. Is that happening with the mRNA vaccine?
I don't know the answer. I don't know I haven't seen that done. I will ask the people that are doing the work if they've looked at an isolated group of vaccine injury. Part of the problem with those studies is that, a lot of people have refused to accept the fact that there is vaccine injury. So I do think it would be useful for the FDA to come out and be very clear about vaccine injury and get the data out. And it would really be greater if they'd come out with a definition of vaccine injury that the rest of us can use to go to the bank with.
When you say a lot of people don't believe it, I mean, when you say that, you don't mean, and public health officials know, you're talking about the day-to-day researchers or doctors, like who are the holdouts at this point? Who doesn't believe it?
Oh,
And is it even honest? Is it just dishonest at this point to deny it?
I would think so, but I will say there's still obviously physicians, clinicians. I think there's still public health people that they don't acknowledge the degree of vaccine injury that is relevant. First, I think the public is fully aware that these vaccines can cause injury. I don't think that's where the denial is. I think the denial is in the medical community. And also, unfortunately, still in the public health community. And I think this would be the advantage of the FDA to come out clearly and put out the data they have on vaccine injury and just say, here it is, it's real. Look how long it took people to accept the fact that the mRNA virus vaccines cause myocarditis.
Right. And neurologic injury is
And
apparently
neurological, the same thing.
much more significant and not really being acknowledged. That was one of the things Peter Marks didn't want the public to know, and Janet Woodcock, they actively suppressed that information, and I saw the evidence of that. And
Well, and look how long even the myocarditis, the Israelis had great data, and everyone buried it.
again, we talked a year ago, and I know a lot of people who just want this vaccine pulled off the market. They don't feel it's safe. A lot of scientists feel that way, even if they don't say so publicly. Why do you think it's still on the market if it has all these dangers? And there are other dangers we haven't even discussed.
Yeah, I
Contamination.
think first, I don't think the regulatory agency has, put the information out that they need to put out, and that hopefully under Marty McCary's leadership that will change, and so that we can see the data. Secondly, I mean, I think you have to assume it's corporate influence. You got Pfizer and Moderna. These are powerful companies that I think are able to counter. I thought that the mRNA vaccines would be at least black boxed.
Right.
Okay. All right. But that hasn't happened yet. I still anticipate they will be black boxed. But they may put me in a box.
I do know the risk, and I understand what you're saying, but it just seems like the FDA needs to do their job. I mean, they need to be protecting us. I know a lot of vaccine injured people. I know people who have died from the vaccine. I know a lot of people injured from COVID. So I don't think, I think it's all a concern, but at least we can control what the public is getting. There was the concern about the plasmid DNA contamination. I just interviewed Dr. Wafik Eldieri, who I'm sure you know. He's an oncologist from Brown, a very famous scientist, expert on P53. And his lab and his team published a paper about that the mRNA, that the spike protein is suppressing P53. So it's hindering the cancer suppression, basically, is the best way I can put it. And so, is that a concern for you that the spike?
I think if you have that data, I mean, that's where you have to just look at where the data leads. That would not be, a positive signal.
Well, it's out there, and it's people know about it. What is leading to, he raised the question of injection site sarcomas and nearby lymphomas. Isn't that to me, that's so frightening. I actually know a woman who had an injection site sarcoma from the mRNA. So why isn't this being addressed?
It needs to be, obviously. This is why the FDA needs to do a critical, open review of their data on vaccine-associated injury. And get it out in the open. I think it was suppressed for the longest time, and people like Peter Marks suppressed it because people felt if you brought anything up that was negative about vaccines, you were encouraging the public not to get vaccinated. And to me, what they ended up doing is encouraging a lot more of the public not wanting to get vaccinated because they don't believe they can trust the information they're getting from the public sources.
Right.
So I do think, if you do an op-ed or you write something, I do think it's time. Maybe I'll reflect on it myself too. I think it's time for the FDA to come out and open the books on all the data they have about vaccine-related injuries from the COVID vaccines, including the Novavax. And I think if they do them all comparatively, they're going to see much less challenge from the protein vaccine than from the mRNA vaccines. But they ought to do that, and it ought to get out, and then allow the American public to make their things. My own assessment, if I was taking the lead on this right now, is I think there's enough concern that you could consider, well, for sure you could consider reevaluating who should get the vaccine. And I was a big supporter of the CDC's decision to move the COVID vaccines to over 65. Okay. Although they got a lot of criticism for it and a lot of people, got angry at Kennedy over it, the fact is it's the right decision. The vaccine didn't belong in those other populations ever.
Why are people mad at science? You're telling me you don't have data to support giving it to the other populations.
You don't.
What's the argument? Where did they even make the argument if that's the case?
I just think it's an emotional response that I mean, it's the same reason you can hear certain, powerful senators who feel that you're obligated to give a newborn infant hepatitis B vaccine
Right.
based on what data? What
So
data?
that's an interesting one. I mean, it's a sexually transmitted disease. Babies are not having sex. They're not walking. They're not stepping on a needle in, Union Square. I mean, again, these are not, yeah, these
No,
really,
there's no data. There's an emotionalism because he had a patient whose mother had hepatitis B, wasn't screened, and then the baby got it. But we screen mothers now. It's not a way to recommend that every kid should get the vaccine. So the hepatitis B, I think you'll see it with the new ACIP meeting that's coming up. They're going to move to take away the hepatitis B vaccine from infants and newborns and move it to later in life. And you're going to hear the mainstream media is just going to go nuts, as
right.
if this is somehow another view of anti-science and anti-vaccine. No, this is pro-science and pro-vaccine. So it's just, I don't know why people aren't thinking clearly on this subject, but they definitely aren't.
It's very political. Science has become the political weapon of our time. There's a massive, obvious rise of cancer, especially in young, healthy people, not just colon cancer that goes back, since the 2010s or whatever. What's causing this? Are we looking at an oncogenic virus in COVID? Is it causing cancer? And again, alternately, what is the role of, again, we have to look at the vaccines as well.
I personally don't think it's probably driven by COVID itself, but I don't know that. I am worried that there could be an oncology risk to the mRNA vaccines that has been not appreciated because I mentioned, there's, pretty compelling data now that there is non-COVID related nucleic acid in those vaccines. And I don't think it's probably a good thing to give the human body unrelated, nucleic acid, which who knows what it codes for. The Europeans I know are looking at this. I have a friend in London who's very smart. He discovered the original CD4 being the receptor for HIV many, many years ago, Gus Dagalish, and he's really on the bandwagon that these residual nucleic acids are causing. He's an oncologist by training, that are causing neoplastic disease, and a lot of them are saying the reason younger people now are getting all these we're getting colon cancer in the 20s and stuff like that, is potentially an iatrogenic consequence of these vaccines. I do think the one thing that's factual is that there is a movement of younger people getting neoplasms now that we didn't have them 25, 30, 40 years ago. What's causing it, I don't know.
They seem to be diagnosed pretty late, and these young people seem to be dying very quickly.
Yeah, and it's because we don't look for it in younger people right now. They need to be more educated, to keep a more open mind about the potential of neoplastic. Most clinicians don't consider neoplastic disease in people under 45. I mean, is it what Kennedy would mentioned about carcinogen toxins and poisons that are in who knows? I don't know.
I mean, I'm sure it's a combination of things, but why the rise now? Why this sudden rise in the last few years?
And then that raises a concern because you basically, could it be a consequence of some of these vaccine policies? The answer, we don't know. But I do think you can't just say, oh, no, it couldn't be. You should investigate it.
Yeah.
I mean, there's enough people that have not been vaccinated with the COVID vaccines, and enough people that have been vaccinated with the COVID vaccines, that you should be able to do a case-controlled study and try to see if there's a signal or not.
Do you know if that work is being?
I have no idea. I would say probably not, which is unfortunate because I think the climate was historically, and maybe it will change, with Kennedy and Jay now for sure. And Marty, the climate was, you didn't look at this.
Right. That's true. I don't know that there was ever such a prominent and alarming rise in cancers and just strange diseases in in such young people, even babies, like Pat Soon-Shiong. I'm sure you know him as well. He talks about a young child in his clinic that had pancreatic cancer and died.
Yeah.
He talks about, I think, a 9-year-old with colon cancer who died. It's astonishing. Kiko Iwasaki, who is an immunologist at Yale, I know you know, but other people may not know who she is. Amy Prohl from Polybio, David Petrino from CORE, Mount Sinai. A lot of them are looking into chronic Lyme and how underlying vector-borne diseases are causing obviously global disease, but also contributing to long COVID. I know there's some very compelling research that's going to be coming out by the end of the year on this that sounds really supportive of that. Have you had any further thoughts on chronic Lyme and chronic vector-borne diseases driving long COVID or other diseases?
Well, I think, clearly and this is one thing that chronic COVID has helped many of us to do, is to relook and keep a more open mind about some of these other chronic infectious disease insults that may be happening with the body. So there's no doubt that there's people that are suffering from post-Lyme, chronic Lyme consequences. And there is a lot of overlap to some of the stuff we see in chronic COVID. Whether or not chronic COVID then triggers a more aggressive expression of illness in people that are also suffering from chronic Lyme. I know there's some people that think it does.
Is it waking
That's
up
right.
these dormant beasts
That's
that are
right. That's the question, that it's triggered an environment to allow these pathogens that are still present.
yeah.
And some of them relatively rare, like babesiosis, for example, to re-express their clinical consequences. I think we got to keep an open mind. I mean, I think there's more going on there than meets the eye. In a way, it's unfortunate for the patients that have had chronic Lyme, because I don't think they've been treated as well as they should have been by the medical establishment.
That is true.
And I think the medical establishment needs to be more humble about what we don't know. There's a tendency when we don't know the answer for us to be dismissive. This is the problem that people have with mRNA vaccine injury. This was the problem people had for the longest time with just long COVID. I tell the story of a wonderful woman in her mid-50s. Her name's Joy, which is the same as my wife's name. And Joy came to see me and with her friend. And Joy was a very successful executive woman who'd gotten COVID and who now had severe cognitive dysfunction. And her cognitive dysfunction was so severe that Joy couldn't remember the third or fourth word in a sentence that she wanted to say. So she talked in 2 or 3 word phrases and then paused for a minute or two till she came up with the next 2 or 3 word phrases. And I told Joy, Joy was actually the very first person I finally decided to use my ideas about treating with Maraviroc and rapamycin and probenecid. I'd had the idea, but I just hadn't done it. I hadn't done it because, at the time, Maraviroc still wasn't that cheap, and it still isn't, depending on where you get it, depending on what pharmacy you go to. But I saw her at the end of it, and I said, Joy, I need to tell you, you're the absolutely sickest person I've ever seen with cognitive dysfunction from COVID. Well, she immediately started bawling, and her friend was with her, started bawling. It was very awkward. And I had her leave and set an appointment for her to come back next week, and we'll continue, our conversation about this and what we can do about it. And I told my wife the story, and Joy, when I got home, said, I thought you had a better bedside manner. You should have been more gentle with the woman. You made her cry. And I said, well, I just told her the truth. And so the next week I saw her and I said, Joy, first I want to apologize to you for telling you the truth. Because you are the sickest person I've ever seen from cognitive dysfunction. but maybe I could have done it in a kinder way. And she stopped me, and she spoke in 2-word phrases, so it took about 15 minutes for her to say this. She says, Dr. Redfield, I didn't cry because you said I was the sickest person you'd ever seen, cognitive dysfunction from COVID. I cried because you're the first doctor that acknowledged I was sick. And that summarizes what it was like back then. These patients, this was about 4 years ago, these patients had basically been told there's nothing wrong with them.
So for 40 something years, this is what chronic Lyme patients have been told. And
No, well, that's why I said the chronic Lyme patients need the same sense of apology from the medical establishment.
Why are we still suffering like this? I know that it is known at the upper echelons of public health that Lyme is chronic, but Bartonella, these are really big problems, okay? These are pandemics of their own. The medical community is not made aware. So again, we're treated the way the long COVID patients were treated in 2022 and 3, and even sometimes now, where they're not believed that it's a real disease and real problem. Why? I don't understand.
Well, it's because people can't get a simple diagnostic test to prove it. I mean, you have the American Society of Infectious Disease that have pretty much come out aggressively saying there is no persistence of Lyme. And then you have the
But they did all the studies that showed that it was persistent. That's the thing that's crazy. Why do they say it?
They come out aggressive. Then you have the Lyme literate group that's there and dismisses the infectious disease. It's an inability for the medical community to, I think, it's sometimes to be humble and say, we don't know the answer. And as opposed to being dogmatic that they know it and this is the way it is. This is the same thing we saw with COVID and COVID vaccines and the policies that were driven by Tony and others. It was not an open, reflective, we're not sure. I remember telling Fauci on a number of occasions, I would answer the question, I don't know the answer. And people would look at me and say, well, wait a minute, you can't say that. You got to give an answer. And I said, but I don't know the answer.
Well, I think anybody appreciates hearing that from you and from anybody who doesn't know an answer rather than just saying anything. But I appreciate that you acknowledge the chronic Lyme disease sufferers. I appreciate that you acknowledge the long COVID sufferers and vaccine injury sufferers. That's a really big deal. And I hope that clinicians will listen and hear you and take that in because we need more understanding and more recognition.
Well, we should push. We should push, and I'll do my own pushing. We should push for the FDA to have an open, transparent review of the safety profiles of these vaccines. So, because that will be an opportunity then to really alert the medical community that there really is a risk-benefit ratio to these vaccines. Because right now, I can tell you, the public believes it, but I don't think the medical establishment believes it.
That's because they have been misled. Yes, I agree with you. And I believe that that's come from the upper echelons of public health not being transparent with them. And then they get it. I know a lot of doctors have gotten long COVID. They're now saying, oh my God, I'm so sorry. I didn't believe it. I thought it was a psych disease. So you did this great roundtable, which we mentioned earlier. Do you feel that RFK and all of you there's a real honest push to really find treatments and great diagnostics for people with long COVID? People want to know if it's real.
Yeah, there's no doubt in my mind it's real. And the question is, how is it going to get operationalized? I had dinner with Jay Bhattacharya just Wednesday night to reemphasize this, how important it was to develop a comprehensive program for long COVID, particularly from the point of view of pathogenesis, diagnosis, and therapeutic intervention.
What does he say about it?
I think he's realizing that this should be a priority. And he told me that autism, Alzheimer's, and long COVID were going to be priorities of his. I think all three of them have a reason to be prioritized right now. In terms of understanding pathogenesis for, say, autism and the multiple different causes of it, understanding the spectrum of disease of Alzheimer's and getting more aggressive about intervening in individuals that have what I would call stage 1 Alzheimer's, rather than waiting for people to be overtly demented. And now that we have treatments that look like they can be efficacious, let's try to move them into earlier patients, rather than wait until they're already not thinking clearly. And of course, with long COVID, I think we need, pretty aggressive approaches to pathogenesis, developing the ability to measure the virus or the consequences of the virus in vivo, and then an aggressive, approach to to therapeutics. And I suggested to him, and I've suggested this to Kennedy. We should have more of a warp speed type approach towards our approach to long COVID, where we look at lots of different ideas and really engage the private sector. The reason the COVID vaccine programs were successful in developing those vaccines, whether people believe they were successful in long term or not, was that we got the private sector involved. Well, we need to get the private sector involved in aggressively developing therapeutics for long COVID. And not just rely on academia, which has a role to play, but it's really the private sector that solves problems, and try to get the private sector more aggressively involved in this illness. It's probably 20 or 30 million Americans. It's not a small sample size of people that their lives are being negatively impacted by long COVID. Most of them don't know it. But I can tell you it's huge, the number of people that are, they probably attribute to the getting older, just not as good as they used to be, but they really got long COVID. So I think Kennedy's approach, it's real. I think you're going to see some action.
Great.
I think.
Can we get you guys working with Polybio with Amy Prohl?
Well,
and
I talked
team?
to Amy. I talked to Amy about helping her. I had a long talk with Amy today for about an hour and a half about ways to try to help her with ARPA-H and in general, to take advantage, of the network that she's established. And at the foundation, I didn't know, hadn't had the meeting with her before I had dinner with Jay, but I will talk to Jay about it afterwards.
Right.
We don't have to recreate the wheel. If they've got a network already established of really good people across the country, both clinical and thing, then learn how to co-opt that in a private-public partnership and get that fully engaged with some of the support, public support, that can be provided by an institution like NIH or ARPA-H. I don't want to see it controlled by the federal government because it moves about as fast as a turtle. But I do like the private-public partnership where the public sector helps contribute some financial security, the ability to move a little quicker from a financial perspective than, say, the private sector is willing to risk. But I think she's very smart. She's onto something. She's got a good group. She's done well, even in her own. I tried the first thing was really to try to get Kennedy to have a discussion about long COVID, which he did. You saw the panel. I think the people that he did invite were good. It would have been nice if it had been nice to have Amy there too. She would have been a great contributor to it. And hopefully, if we have follow-ups, she'll be involved. And the key with NIH is to get them more involved and get them thinking outside the box. It doesn't help. I mean, when you look at the Recover program that they had, it really is highly non-innovative, and it really kind of depressing that was their response to the COVID pandemic.
I've gotten some very upset phone calls and correspondence about how they basically wasted over $1 billion.
1.7.
Okay, so close to $2 billion. And I've asked where did that money go? Nobody can tell me.
The study did, the 15 days of Paxlovid, and some of the money, it got recovered. So, I've talked to Jay about reprogramming that money.
Good.
So I think only about half of it was spent. So some of it's recovered. And the question is, can he get that out the door in a much more innovative way? Their current program internally, they ought to just I mean, as I told Amy, they ought to just put out a proposal and let outside groups bid on taking over the intramural responsibility for long COVID.
Yeah.
Because their extramural program was really non-innovative.
Yeah, unfortunately, it did seem really did not deliver the way we all had hoped. So I understand too that one of the next things that's going to be happening is a roundtable on Lyme. Sorry to keep bringing up Lyme, but it's an important topic. RFK has Lyme. His kids have chronic Lyme. Jay and Marty, I know, both expressed concern about it, and they've both read Chris Newby's book, Bitten: History of Lyme and Biological Warfare. They have a lot of concerns about how Lyme patients have been mishandled. So will you be part of that if that is the case, if there is this new push to solve Lyme? Will you be part of it?
I don't know. I don't know the answer. I will be part of pushing that they go forward with they're supposed to have a follow-up roundtable, on Lyme, and I do think there's a lot of overlap. If you read the Nature paper that was recently came out, I don't remember who wrote it, but very interesting to me, some of the similarities of the cell-mediated immune defects that we're seeing in some of these chronic Lyme, as well as obviously COVID, as well as some of these other chronic inflammatory diseases. So I hopefully that will, and obviously, if Kennedy asked me to partake, I will. But I'm glad that he's starting to look at these with a fresh pair of eyes.
I am too. So we're almost done here, Dr. Redfield. You're such a sport. I have a couple more questions, if that's okay, and then you can go have a drink,
Okay.
which I think you'll need after this interview. So Dr. Redfield, the Trump administration promised full transparency on the pandemic origins, and I've got a lot of biosafety people in my life who are upset that nothing has been released and want to know if it's coming and why hasn't this promise been delivered on.
I'm disappointed too. The head of the CIA, is a good guy. He used to be the head of intelligence for the United States, and we thought that this would all be out in the open 6 months ago. So I don't understand why it's not all out in the open. I expected all of the intelligence agencies to revise their assessment. The CIA has, and I think the Defense Department has, but I expect all of them to revise their assessment, and I expect a unanimous conclusion that this virus came from a laboratory in China through gain-of-function research, because I think that's what the evidence is.
What about the U.S. part, though? What about you?
Well, I think the U.S. was a big proponent of it. I mean, they did. We helped fund it. We had scientists involved in it. I mean, probably the clones that were used to help create this virus might have even originated from the United States, North Carolina's group.
Right.
So I think this. We need full transparency. We haven't got it. I don't understand why. As someone who's brought this up and got death threats and got sidelined because I suggested years ago that this virus came from the Chinese laboratory. I mean, one of the reasons my book never got published, it got put out to a variety of different major publishers. And they all eventually rejected my book, except for Skyhorse. And the reason they rejected it was they thought it was inappropriate that I suggested that the COVID virus came from a Chinese lab.
And a U.S. lab. I mean,
And
let's
a
just be honest.
U.S., but they were.
I mean, the U.S. I'm not letting the U.S. off the hook. I'm not.
I'm not either. But I'm just saying they were upset. They didn't reject my book for what I said about the U.S. government. They rejected it from what I said about China.
Why do you think that is? That's interesting.
I have no idea. Some people feel the Chinese have a lot of influence on our publishing industry. But luckily, Skyhorse offered, and then so a year and a half later, my book is finished. It'll be out on November 4th. But I think there should be full transparency. And John Radcliffe, he knows my view. John knows what happened. He has no doubt that this virus came from the Chinese lab, and I think the United States ought to just put everything out and open. And I agree with you. They should put it out in the open. The role that University of North Carolina played, the roles that EcoHealth played, the role that NIH played. You probably also know that the Defense Department helped fund this research. The
Correct.
State Department helped fund this research.
Correct. Yeah.
And NIH helped fund it. I mean, it got funded by the State Department, the Defense Department, USAID, and NIH. So.
Right. So
And that's why I've never, when people accuse me of sort of dumping on China, I said, wait a minute, this is a U.S. Chinese. The United States is very much responsible for this, as the Chinese are.
So shouldn't anybody be held accountable for
That would be
all
nice. It would be
these
nice if
deaths
that would happen. Okay, I don't understand. I guarantee you, if it was me that did this, they'd be lining up to hold me accountable.
That's right. That's right.
But so I don't understand why certain people are getting a free pass on this one. I was hopeful that Trump administration, President Trump, would release all of the classified information. It's still not all been released, even though Congress passed unanimously that it should be released. And I just don't understand why it's not all being released and let the American public see all the information that we have, which is, the House has tried to do their job. Colburn's tried to do his job. But I don't understand. I mean, is it geopolitical? Is there something bigger going on that you and I don't understand? I don't know.
I think we may never really know the truth. So I have to ask, because I missed this on our last interview, and we talked a lot about self-spreading vaccines and this new technology and stuff. And there's been some talk about whether Omicron was intended to be a self-spreading vaccine. I need to ask you if you think.
Yeah, I think it. I mean, I'm my own view, and again, it's just a personal opinion.
Yeah.
My own personal opinion was the entire program was designed to make a vaccine vector that could be used as a vaccine for a variety of different antigens, including COVID, but also including everything else, as a self-spreading, aerosolized, respiratory transmitted vaccine. Yes.
What I'm saying, yes. What Omicron specifically, okay, very different than Delta, very different than the prior three. I talked to several virologists and other people who study viruses who said this was released as a self-spreading vaccine to get everybody.
You needed the vaccine to evolve to a vaccine. You needed the virus to evolve to a vaccine that didn't cause much illness. Okay, and that's what happened with Omicron. You also needed it to change where it replicated. If you want the virus to be spread, it's a lot easier to spread a virus that replicates in the upper throat than is one that replicates in the lower lung. So there are some people that believe that this was part of creating a vaccine vector.
Yes, and it sounds like you are.
I don't disagree with it. I don't have. It's a personal opinion. I don't have data, but I think it was I think there's pretty clear data. That the Chinese were working on a COVID vaccine probably before the COVID pandemic started.
Right. I'm just asking specifically if Omicron was released to shut down the lower lung destruction that was happening with Delta and the other variants.
It obviously resulted in that. Was that done intentionally? I don't know the answer.
Okay. Jeffrey Taubenberger, very controversial figure. He's the new NIAID director. People say that he is almost exactly like Tony Fauci. He revived a deadly 1918 flu virus that killed millions of people. Biosecurity world is up in arms about his appointment. What do you think about his being there?
I don't know him personally, but again, I'm very much of the view, as I did on my Wall Street Journal op-ed piece with Mark Siegel, that we should have a moratorium on gain-of-function research. So everything that he's done, I consider to be unnecessary and potentially careless.
Yeah. Do you think he might be replaced by somebody who's okay?
I think it's I think there's high probability in my view, but
okay.
Jay's got to figure out what battles he wants to fight,
Yeah.
and who he wants to put in the position. But I thought it was a poor choice. I think his scientific judgment is too similar to Fauci's judgment, which I think got us into the pandemic.
Exactly that. The PrEP Act was extended through 2029, and that's for COVID medical countermeasures, which include COVID vaccines. And this grants immunity from liability to everyone involved in COVID vaccines and other medical countermeasures. Why was it extended, do you think? And should it be repealed? People are concerned about this as well.
I'm a firm believer that the industry should not be protected against liability. I think it's a big mistake.
Mm.
And hopefully those things will be repealed, because I don't think the industry should be immune from accountability.
Yeah. So, COVID vaccines are inherently, the mRNA are gene therapies, correct? You can just go on the record that these are
I
gene
think you'd
therapies.
have to say the mRNA vaccines. I would
Yes.
say that the protein vaccines aren't, but the mRNA vaccines are a form of gene therapy.
Right. So given that, shouldn't they be required to be held to a different standard? Shouldn't we have better oversight, more informed consent?
They sure should be held to a better understanding, as we mentioned earlier. I mean, I don't know how they got approved without knowing, when I give an mRNA vaccine to you, I have no idea how much spike protein you make and how long you make it. I think we should have had clear data on what the spectrum was of how much spike protein is made and how long you make it. So I do think the platform kind of got approved without getting some of the critical scientific questions answered that would relate to safety and efficacy and the consequences in the human body. I think they should have a different standard than, say, a protein vaccine or a killed vaccine or a recombinant vaccine. An attenuated vaccine. So I don't think they should have just been thrown into the same vaccine group. Now Peter Marks will argue he was responsible for gene therapy, so he was kind of the guy, and that's, but no, I do think they should be not equated with regular old vaccines.
Why was there also just this weird dogma around calling it a gene therapy? Why is that? That's really strange to me as well. It says it on the insert.
You mean that they didn't call it?
Well, yes, that's what I mean.
A lot of bad press obviously happened with the Pennsylvania death, from the adenovirus. Gene therapy was put on a hold for the longest time. There may be some regulatory hurdles that were there if it was called a gene therapy. I don't know. I'm not a regulatory expert. But it clearly is a gene therapeutic approach to intervention for human disease.
Yeah, I guess the optics maybe is what you may be referring to. Is gene therapy in our future to solve some cancers?
Well, I do think the mRNA technology probably will. I'm of the view that the mRNA technology will no longer be used for preventive vaccines. I think it will go bye-bye in the next year or two. But I do think the technology is going to be exploited for therapeutics. One of the reasons I think that is the ingredients. The beautiful thing about the mRNA technology is I only need 4 nucleotides, and they can store on the shelf forever. And that's what I need for me to make probably a nucleic acid for anything that I want to do, and along with a couple of enzymes.
Right.
And my own view is that there's going to be a limited supply of those reagents, and if there's a choice that we use them to cure human disease, or we use them to prevent something, the American public's going to want them to be used to cure disease. I also think the risk-benefit ratio really gets shifted enormously.
Yeah.
If I'm using this technology, this platform to cure cancer, or to successfully treat cancer. It's a whole different formula than if I'm using this for a vaccine to vaccinate children against a disease they may never get.
Yeah.
So I do think the mRNA technology is important technology for therapeutics in the future, particularly for cancer, maybe for some immunological disease, neurological disease. I just don't think it has a role in preventive vaccine development in the long run.
Okay, and that's important distinction because there's, again, a lot of talk that people are misinformed about it because there's been a lot of spin that the government is canceling all mRNA vaccine funding, but it's against respiratory viruses from what I
That's right.
understand.
All
And
we've
that's it.
canceled so far are just respiratory viruses. It's not even been canceled for other viruses, preventive,
Right,
and it's being advanced for therapeutics.
right.
So I think the platform's an important platform.
Mhm.
I just don't think it's probably, has a role in preventive vaccine development. As the CDC director, I like having the technology in my back pocket if a new pathogen comes and I need to try to develop a vaccine, within 6 weeks. So I can do that with this technology. But I don't think it needs to be routinely used for human preventive vaccine development. But I do think, Moderna and other companies are really moving quickly in developing certain cancer therapeutic products using the mRNA technology. And I do think it's going to have an exciting role there.
So I know you're concerned about bird flu and another pandemic. And my last question to you is if you were CDC director now, today, what would you advise for all of us? What are your parting words for our future and your concerns for public health and pandemics?
Well, I think we need to aggressively prepare for the bird flu pandemic. Okay. And as you read in my book, and particularly in the last chapter, I kind of lay a lot of it out. And so first and foremost, we need to invest much more heavily in antiviral drug development. I remind people that we had one of the most successful vaccine development programs in the history of mankind, and we've lost millions and millions of people from COVID. So the answer is not vaccines. The answer is effective antiviral.
Can you explain that? Just because I think, again, the public doesn't understand. They want a flu vaccine, but they don't really know the flu vaccines don't work well to begin with at any time. I think that the medical establishment, largely knows that, but I think that generally people are conditioned to just think, I need to get a flu vaccine.
Yeah,
So,
flu is a good example, as you point out. So if you look at the flu vaccine, on the best years, the vaccine that we develop, and we develop a new one every year, the best years, 50% of the people who get the flu vaccine will be protected against flu. So that means 50% of people won't be protected. All right. On the average
does it
year,
stop transmission? Is it like
it can interrupt transmission, but doesn't stop it necessarily. And if I'm vaccinated, 50% of the people that are vaccinated are still going to get flu. Or the year I was CDC director, it only worked 25% of the time.
But when you say it only worked, are you saying it reduces disease severity, the symptoms?
No, I mean it prevented infection. Get the flu vaccine, 50% of people who are exposed to flu will get flu, and 50% of people won't get flu. The year I was CDC director, the first year, 25% of the people who got the vaccine were protected.
That's terrible.
75% of the people weren't protected. All right.
How can we even justify giving this?
Well, and it's not. It's like the COVID vaccine. It's not very good at preventing infection, and that's why antiviral drug development is so important. All right. And so, the company that I'm working with right now, we have a great flu drug, and it works for all bird flus. It works for regular flu. It works for Tamiflu-resistant flu. It works for baloxavir-resistant flu. I think it's a great drug. Personally, I think it could replace the flu vaccine because this drug is so good. I have to give you one pill every 3 to 4 weeks, and it will protect you.
For the whole season?
Well, that's what I mean. If I have one pill every 3 or 4 weeks, you could argue 6 pills will take you through the whole season.
So suppose you got the flu, right? You didn't have the pill, whatever. Will it reduce the symptoms and will it keep you, from getting really sick from the flu?
No, once you're infected with the flu. I don't think there's any evidence that it's going to have any meaningful secondary impact. So one of the realities is the flu vaccines don't work very well.
Right.
Okay. When I was CDC director my first year, we lost more children from flu than any other year in the history of our nation. And what those children had in common, well, of course, was they weren't vaccinated. So you could argue that maybe there was a reduction in symptomatology, but I wouldn't go to the bank on that. But the flu vaccines do not really work very well. And that's why antiviral drug development's important. I'll argue the COVID vaccines don't work very well in preventing infection either. That's why I'll argue for antiviral drug development. The antivirals work pretty well. If you get infected, they work in preventing significant disease and getting rid of the virus. There's pretty good data that if I do treat you early, say, for example, with flu, with antivirals, there was a paper in the New England Journal, there was decreased secondary transmission in the household. So I'm more of the view that we need to move to more effective antiviral drug development.
Right. And I want to just go on the record as saying there was a study, I read it recently, I think it was also Cleveland Clinic, though don't quote me, that said that the 24-25, that the flu vaccine recipients had more flu than the non-influenza vaccine recipients. They were more susceptible. So there's a lot of stuff that's kind of weird going on here.
Well, the flu vaccine doesn't work very well, and I think that's part of the problem with the American public. And when I was CDC director, you asked them about the flu vaccine. They said, well, I got the flu vaccine. I still got flu.
Right.
I got the flu vaccine. I still got flu. So the average person, I think, in the American public doesn't believe the flu vaccine works very well. And guess what? They're right. It doesn't work very well.
Right. So we do need new effective antiviral strategies, as you said. Well, Dr. Redfield, your book is fabulous. It's called Redfield's Warning, What I Learned But Couldn't Tell You Might Save Your Life. I wish you a bestseller, and I thank you for all your efforts to help so many people.
Well, thanks, Dana, and thanks for giving me time.
Thank you so much, Dr. Redfield. Thanks a million.
God bless. Bye-bye.
You too. Thanks for joining us today. Please subscribe or follow along for more really interesting conversations. And I'd love to hear from you. So please drop a comment or send me a note. Let me know what you think.